So we'll be starting with pachychoroid spectrum diseases. Yeah. So as you know, pachychoroid is the choroid is a multifunctional layer of the eye, and it has an important role in the pathophysiology of numerous ocular disorders. And the term pachychoroid has been used to describe abnormal and permanent increase in the choroidal thickness. The pachy means thick, pachychoroid means thick choroid, but this is not the only criteria. So the normal subfoveal choroidal thickness is about 191 to 350 microns, but it increases with age, axial length, and refractive error. And more than 300 microns is considered to be pathological, and it's seen in conditions such as central serous chorioretinopathy and polypoidal choroidal vasculopathy. The two OCTs, that is the enhanced depth imaging and the swept source OCT, have revolutionized the way we look at it and image the choroid. This is a swept source OCT of retina and choroid, and not only the various layers of retina is seen, but also it shows the choroid quite clearly, including the choroidal scleral junction. And the choroidal structures can also be imaged clearly, that is the choriocapillaries, Sattler's layers and Haller's layers, and even the choroidoscleral junction. Now, coming on to the pachychoroid spectrum, it includes the pachychoroid pigment epitheliopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, polypoidal choroidal vasculopathy, and two new entities, that is the focal choroidal excavation and the peripapillary pachychoroid syndrome. And the imaging modalities include fundus examination, OCT, ICG, and this is a fundus examination in which it shows the reduced fundus tessellations overlying the areas of choroidal thickening. And the enhanced depth imaging OCT shows here there is choroidal thickness of about 500 microns, and it is a diffuse thickening. Also, it shows pachy vessels with dilated outer choroidal vessels and the choriocapillary compression. The ICG shows delayed choroidal arterial filling, dilated choroidal vessels, and the midface shows multifocal areas of choroidal vascular hyperpermeability, which is an important feature of pachychoroid disease. Now, coming on to the pachychoroid pigment epitheliopathy, it shows a reduced fundus tessellations with RPE changes on foveal motility, foveal mottling, and it is seen basically in the young patients and in the other eyes of patients with CSR. The OCT of PP, it shows undulating RPE alterations and the choriocapillary compressions or the pachychoroid and the pachy vessels. And the enhanced depth imaging OCT shows thick choroid, dilated outer choroidal vessels, choriocapillary compression. The fundus autofluorescence shows stippled hypoautofluorescence, and the fundus fluorescent angiogram shows stippled fluorescence, and the ICG shows pachy vessels along with the late phase choroidal vascular permeability. Now, coming on to the central serous chorioretinopathy, it's a serous macular detachment at the posterior pole associated with RP leak and choroidal hyperpermeability. And FFA, the typical point leak in early frames with an ink blot pattern is seen, which is seen in 93% of cases. And in 7% of cases, there will be early point leak forming smokestack leak. This is a OCT of an acute CSR. It shows serous macular detachment under the fovea, separating the neurosensory retina from the RPE, along with associated pachychoroid features and thick choroid. This is a OCT of a fibrinous variant, where under the neurosensory retina there is hyperreflective material with fibrinous exudation, and in this case it is associated with a serous PD with a hyporeflective sub-RP space. Now, the fibrinous material in the subretinal space causes two OCT signs. One is the bridging tissue and one is the contact sign, where the neurosensory retina dips down to touch the underlying retinal pigment epithelium. The fibrinous CSR compared to the normal CSR, here there is a hyperreflective material in the neurosensory detachment and a round hypoechoic space inside the vacuole sign, which is a fibrinous variant of CSR. Now, the chronic CSR, when the submacular fluid is persisting for more than 4 to 6 months, we call it chronic CSR. And here you see an RP degeneration along with the RP inferior tract known as the teardrop CSR. And the OCT finding shows foveal thinning, disruption of the ellipsoid zone of the outer retina, the outer segment elongation of the photoreceptors, and shallow irregular separation of the RP from the Brooks called the double layer sign. The other findings include intraretinal cystoid space in this variant called the cystoid macular degeneration or the CMD. This is a picture of late cystoid macular degeneration or the CMD, where the subretinal fluid has disappeared or resolved and there are large intraretinal bullae of the cyst. The EDI OCT or the sepsis OCT also shows diffuse choroidal thickening, or it can be a focal choroidal thickening. And this is an OCT in which it shows choroidal hyperreflective dots seen in the chronic CSR, which suggest an inflammatory origin to the pathogenesis of CSR. The ICG will show early phase findings include delayed choroidocapillary filling, the Pachy vessels, and the mid phase shows multifocal hyperfluorescence, and the late phase shows choroidal washout and choroidal vascular hyperpermeability. Now coming on to the pachychoroid neovasculopathy, it is a type 1 choroidal neovasculopathy overlying the focal choroidal thickening in the absence of drusen or myopic degeneration. This is a fundus picture showing reduced fundus tessellations or shallow irregular PED, suggestive of type 1 or subretinal neovascularization. And the OCT shows, the enhanced depth imaging OCT shows shallow or irregular PED with sub-RPE hyperreflectivity, signifying the presence of neovascular tissue overlying the Pachy vessels and the thick choroid under the neovascularization. The FFA and the ICG, it shows stippled hyperfluorescence on FFA and branched neovascular network on ICG. This is a branching neovascular network which is seen in OCTA, and this is a safe, non-invasive, highly sensitive area. Now coming on to the PCV, it is characterized by serosanguinous pigment epithelial detachment, and it is basically diagnosed by the orange subretinal nodules and the halo of hypofluorescence, massive submacular hemorrhage, and polyps. Coming on to the types, it can be hemorrhagic, exudative, mixed, or the periphery PCV with chorioretinopathy. And the ICG is the gold standard, and the late ICG features will show the late hyperfluorescence. The OCT, it shows tall peaked PED, notched PED, a thumb-like PED, or the double layer sign, which is a classic feature of PCV. And this is a classic notched PED seen in the PCV with a hyperreflective ring-like structure signifying a polypoidal lesion. And now we have a double-layered sign, that is the RPE being separated from the Brooks membrane, and a notched or a multilobulated PED with sub-RPE hyperreflectivity signifying PCV. So now coming on to the focal choroidal excavation, that is this is in a spectral domain OCT. There is an area of sharp focal choroidal excavation in the absence of disease like high myopia, and it can be of two types, that is a conforming type or the non-conforming type. The neurosensory retina attached with the focal choroidal excavation with intact ellipsoid zone, whereas in non-conformating there is a separation of the neurosensory retina from the RPE. The association, it can be associated with CSR, CNVM, and polypoidal choroidal vasculopathy. Now coming on to the last, that is the peripapillary pachychoroid syndrome. It's a unique entity in which the features include RPE motlating, late disc leakage, and choroidal folds. This is the OCT which shows subretinal and peripapillary intraretinal fluid with cystoid degenerations and nasal choroidal thinning and nasal choroidal macular thinning and hypertransmission defects. Thank you.
Thank you, Dr. Basil, for that rundown on pachychoroids.